Okay, welcome to Pediatric Grand Rounds. Thank you all for your attendance today. I appreciate everyone coming and being on time so that we can begin. Today we're going to have presentations from two of our CHRC scholars. We've had the good success of having a number of outstanding scholars supported by this grant over the last 5 years. And even though the grant now has ended, we still have a tracking process where we're encouraging and working with our scholars to continue to ensure their career development and success. And so we've been able to support a number of physician scientists on this award, Heather Stefanski, Terry Laguna, Shane McAllister, who will be presenting today, Annie Hall, and then last but not least, our first speaker, who's Dr. Tate Gisslen. Tate's an assistant professor of pediatrics in the Division of Neonatology, and he'll be talking about his area of investigation, fetal inflammation and the developing brain.
Well, thanks for having me here today to talk about our research. I have nothing to disclose. So this is how life in the outside world begins for the very premature, with an abundance of tubes and wires anywhere they can fit, bright lights and being poked and prodded at all times of the day, and pretty much the exact opposite of where the baby is supposed to be at this time in life. Fortunately, the survival of these extremely premature infants is improving because of this and also in spite of this. But fortunately, survival is improving. One of our biggest worries in these babies is their long-term neurodevelopment, with the goal that they grow up and do everything just like every other child that they go to school with. Unfortunately, this isn't always the case, and in some of these babies, infection and inflammation have already affected them as a fetus and influenced their development beyond just causing their preterm birth. Because infection is the leading cause of premature birth less than 28 weeks gestation. This figure shows the percentage of preterm births at each gestational age with histologic chorioamnionitis, a sign of placental and amniotic infection. And you can see that more than 50% of premature infants 27 weeks and earlier are born for this reason at a time when they're most vulnerable. Chorioamnionitis continues to be an important cause of preterm birth later in pregnancy, but decreases as other problems become more common. Chorioamnionitis is a maternal infection of the placenta and amniotic sac that surrounds the baby and occurs at birth. Mothers show signs that include fever, increased heart rate, and abdominal pain, but not always. Sometimes chorioamnionitis is silent and only a histologic diagnosis, as in the study I just showed. Preterm birth may be the only sign. The fetus is affected first because it's born prematurely, but is affected further as the infection spreads beyond the placenta and when the chorioamnionitis is most severe. This is a disease known as the Fetal Inflammatory Response Syndrome. The fetus may be tachycardic, and funicitis, or umbilical cord and inflammation is seen on pathologic examination. There are also increased levels of umbilical cord blood cytokines. IL-6 has been specifically used to define fears. Unfortunately, when this occurs in extremely premature infants, there are worse long-term outcomes. So how does a happy, healthy baby become exposed to chorioamnionitis? In some pregnancies, the placenta and amniotic sac are exposed to infection, and in most cases it's from normal flora bacteria that, for unknown reasons, ascends from below and then tracks along these tissue layers in the choreo and amniotic tissue, makes its way inside the amniotic sac, and the baby, through breathing, normal breathing and swallowing movements, further exposes itself by bringing the bacteria inside the body. And this sets off the fetal inflammatory response. So as I mentioned, fetal inflammation leads to worse outcomes in the Nicu. This study looked at a group of preterm infants of all ages and found that fears led to increased odds ratio for early onset sepsis, intraventricular hemorrhage, and a combined adverse neonatal outcome of all of these parameters. Long-term neurodevelopmental outcomes are probably our most important measure in the NICU. Unfortunately, fears influences worse outcomes here too. This study looked at neurodevelopmental outcomes of 130 infants less than 32 weeks. As I mentioned, fears or phenocitis is a sign of fears, and I'll draw your attention to this middle column, which is looking at whether babies had histologic phenocitis or not, versus this is chorioamnionitis alone, or whether there was clinical chorioamnionitis diagnosed. And you can see that fetal inflammation and fears led to increased speech abnormalities, cerebral palsy, increased seizures, and an increased percentage of moderate to severe disability. The increased severity of phenocitis, indicating a worse inflammation, also seems to have an impact. This study of infants between 23 and 28 weeks found that those with the most severe phenocitis had a significantly elevated risk in this is a combined neurodevelopmental or death, or either death or neurodevelopmental impairment alone. So inflammation seems to be causing severe problems for these infants. So why does this have such an effect? Well, to get an idea, this is how the brain looks when our earliest babies are born at between 5 and 6 months, where the brain is quite small and the exterior surface is flat. Importantly, you can see how much brain development occurs in the babies while they're in the NICU. You see not only the growth that occurs in 4 months, but also the extreme change in structure that occurs during this time. You can see how physiologic problems or injury during this time period may have a dramatic long-term effect. So inflammation can affect both white and gray matter. To review, white matter is made up of cells in the central nervous system known as oligodendrocytes, and these form insulation around neurons and increase axon signaling speed. And when our preterm babies are born, the developing oligodendrocytes are quite vulnerable to injury. And this has led to one of the more historically important injuries in preterm infants, which is periventricular leukomalacia, which has been frequently studied in part because this has been easily seen on ultrasound. Unfortunately, as preterm NICU care has improved, the severe white matter injuries are less commonly seen. But despite this improvement, many of these infants still have a significant neurodevelopmental problem. So there seems to be injury not explained by white matter disease alone. So gray matter includes neurons and other supporting cells. More recent evidence suggests that early physiologic changes due to a fetal inflammatory response during the extreme prematurity period affect gray matter development and long-term outcomes, but the mechanisms by which this occurs are not known. So looking again at this picture to illustrate the importance of gray matter development, the major growth and convolution that occurs here at 9 months is mostly necessary to accommodate the massive expansion of gray matter. You can see how small changes in gray matter early may be multiplied as the brain grows, leading to very noticeable problems later in life. So one of the mechanisms that appears to be affected by inflammation is glutamate metabolism. In the brain, glutamate is a neurotransmitter that interacts with multiple types of receptors after being released in the synapse. Importantly, when we look at neurotransmitter metabolism, many pieces are tightly regulated. Both synthesis and secretion of the neurotransmitter and the receptors and the reuptake of the neurotransmitter are all important to maintain the right concentration for the right amount of time within the synapse. Excess glutamate or concentration leads to excitotoxicity or too much signaling and subsequent neuronal death. The developing brain like in our preemies, is likely more vulnerable for a few reasons. One, the NMDA receptors, which mediate normal brain development and synaptic plasticity. Also, the NMDA and AMPA receptor activity increases rapidly in the first week of life as the babies are developing. Importantly, these receptors are most dense in the hippocampus and cortex, implying that these regions have a higher vulnerability under excitotoxic conditions. Inflammation and glutamate seem to be very connected. For example, in a rodent model of maternal systemic inflammation, worse neuronal injuries are seen when there's combined inflammation and a glutamate agonist injection within the neonatal brain. IL-6, which is another prenatal maternal exposure, alters NMDA receptor subunit expression in the neonate. In cell culture models of gray matter, LPS added to the culture will increase glutamate with concentration, mostly due to decreased uptake by glial cells. And also in culture, IL-1 beta, which is an inflammatory cytokine, will increase NMDA receptor function, which then leads to an increased intracellular calcium concentration. So it appears that glutamate and inflammation have a tight relationship, especially within these systemic and cell culture models. So because the fetal inflammatory response is often clinically silent in the mother and specific only to the fetus, I've developed aims to address inflammation and injury following fears throughout development. The first aim was to determine the acute and subacute regional inflammatory response and the gray matter injury in the neonatal brain after a fetal LPS exposure. Secondly, to interrogate the mechanisms by which fears regionally injures developing gray matter. So I hypothesized that brain inflammation and gray matter injury will be caused by fears, that gray matter injury will persist despite inflammation decreasing over time. Fears will cause persistent glutamate-mediated excitotoxicity through multiple mechanisms. So to test these hypotheses, I'm using a rodent model of chorioamnionitis and fears. I perform a laparotomy under a general anesthesia and inject each amniotic sac with LPS from E. coli to induce fears on day 20 of a 22 gestation and then allow for a spontaneous delivery. We then measure outcomes when the pups are 7 and 28 days old, and this corresponds with a term and an adolescent brain in relation to brain development. We are looking at genes and proteins of both cytokines and glutamate metabolism. And we're currently in the process of evaluating cell changes in the brain by looking at histochemistry. And we plan on looking at neuronal cell death and both astrocytosis and microgliosis. And we have a little bit of information on that. So here are some of the results that we've found. Here we measured mRNA of two inflammatory mediators, TNF-alpha and IL-1 beta, in multiple organs. Here the gray bars represent those receiving LPS, and black is the control, which received intraamniotic saline. We measured lung and liver to look for systemic inflammation, and then measured inflammation in the cortex and hippocampus, two regions of the brain. You can see at 7 days of age a consistent increase in inflammation in the lung and the liver. At 28 days, there's surprisingly some inflammation still occurring, but that is inconsistent. In the brain, however, we actually aren't seeing any significant elevations in cytokines or inflammation. Whether this is related to the blood-brain barrier or perhaps a mediator inhibiting inflammation in the brain is unclear and deserves some further attention. Similarly, we looked at two other markers of inflammation, the MMP9 and MCP1. also in the lung, liver, and then cortex and hippocampus. We see some early increase elevation in the liver and later elevation of MCP1 in the lung, but otherwise not much change. In the brain, similarly to the other inflammatory markers, there actually isn't a whole lot of, there's no significant change, although there does seem to be a consistent upward trend at P7. So in assessing glutamate metabolism changes, we're looking at molecular level at several of the receptors and transporters. There are three main types of glutamate receptors, each made of a different subunits or types. The AMPA and MDA receptors and the metabotropic glutamate receptors, and the GRK2 protein, which is a glutamate receptor kinase, and this has an inhibitory effect on the metabotropic glutamate receptors. And we're also looking at the glutamate transporters, which are important for reuptake of glutamate from the synaptic cleft. So this is the glutamate receptor proteins in both cortex and hippocampus. Similar to the previous slide, the gray bars are LPS exposed on days 7 and 28. Each graph here represents a different type of glutamate receptor. These are specific subunits of the NMDA and AMPA receptor, along with the type 5 metatropic glutamate receptor and the GRK2 protein. And looking at both the cortex and hippocampus, you can see we have both early and late changes of several of the receptors, decreased protein levels. And the stars represent the statistically significant changes. And it appears that inflammation is, in this model at least, causing changes in the glutamate metabolism. It also is possible that there's different regulation within the cortex and hippocampus with differences in different receptors. These are two glutamate transporters looking at the cortex and hippocampus, the GLT1 and GLAST transporters. There may be small changes, but not a whole lot different that we're finding in the transporters. So I mentioned we're beginning to assess cell changes in the cortex and hippocampus. These are new pictures that we just obtained last week and will soon be quantified, but as a start, this is just some examples of, this is cortex tissue with saline animals and LPS exposed animals at P7, and this is staining for CD11 positive microglia, and microglia are the immune cells in the central nervous system, and at least starting out appears to be quite a difference in microglia in the cortex. Similarly, in the hippocampus, also CD11 microglia, and there also potentially is an increased microgliosis here as well, but this will all soon be quantified and we'll have more information soon on this. While we're working on these experiments, we're also looking at some future studies. Fortunately, many of our infants in the Nicu, in addition to being exposed to chorioamnionitis and fears, are also exposed to postnatal inflammatory events, such as NEC or sepsis. And to model this, we'll be soon giving our neonatal pups postnatal doses of LPS, in addition to the prenatal LPS exposure that they're already receiving. And we'll further assess brain injury in those animals. We'll soon be looking at analyses of the brain during development, including looking at MR spectroscopy to assess energy metabolism and how it may be affected by inflammation. And then we'll also be looking at long-term behavior studies to assess the effects of inflammation in those animals. And then to further look at mechanisms within the cells, we'll be looking at cell culture studies, and we'll be learning more about the mechanisms there. So I just wanted to acknowledge mentors Michael Georgiev, Raghu Rao, and Bob Mizell. Garima is the technician in the lab, and a lot of help that I've gotten from Annie, Katie, and Michelle, also in our neonatology labs, and the CHRC and the Vikings Children's Fund. So thank you very much.
Thank you. We have time for a couple of questions. Dr. Kaplan?
Put into the experimental model, does that affect blood pressure at all of either the pups or the mother? And if so, how do you separate out hypotension from the other effects that you've nicely shown?
Right. So far, it doesn't seem to. We don't measure blood pressure in the moms. This model I've sort of adapted from the literature a little bit, but also from sheep experiments that I was doing in Australia. And essentially those moms, like many of the human moms, don't seem to know that they have a problem. And the only problem that we tend to see are preterm delivery and inflammation of the amniotic tissues and umbilical cord.
But you don't know about the blood pressure?
It hasn't been measured. It doesn't seem to be a problem, at least in animal models.
It has been.
It hasn't been measured here. Sorry.
Other questions? I'll ask you, Tate. You're injecting the rats at day 20 of 22 of gestation. So is it really a prematurity model?
Right. So you're right. The babies are born at term. Literature from others that do rat work and premature work, especially in HIE models, suggests that at least as far as brain development goes, the brain is more developed like a premature infant when the rat is born. So that's why at P7 it seems to be more like a term human, even though the rat itself is a term baby. Although others, other people who write and have done other inflammatory experiments, they call this a term animal. Fortunately, we can't keep preterm rats alive. That doesn't work, so this is as close as we can get with preterm rats.
iCook has no rat NICU. The microglia data are quite intriguing, and given that these are professional cytokine-producing cells, it might be interesting to use an array to look at a broader swath of cytokines than the ones you've looked at. Maybe you'll find some interesting associations. Well, we need to move on. Thank you very much, Tate. And our second speaker then will be Dr. Shane McAllister. Shane has been a very productive CHRC scholar. He's had two very high-profile papers this year, one in elucidating the outbreak of enterovirus 68 or EV68 in our pediatric ICU a year ago, and then a second paper now published in Journal of Virology in his primary area of focus, which is KSHV, Kaposi Sarcoma herpes virus. And for the residents in the audience who may not be familiar with that virus, I think he'll give us a little bit of background in addition to some of his data.
Thanks, Mark. Hello, everyone. Yeah, so I'm going to talk about a disease that many people in this room probably have not seen, but hopefully I'll convince you that it's important to look at this nonetheless. The disease of interest here is Kaposi Sarcoma. This is a cancer that is divided into four epidemiological categories. These two forms the endemic HIV negative or HIV non-associated cancer, very highly prevalent in Africa, as well as AIDS associated. All four of these have a similar look on gross analysis. Dermal lesions are dark red. There's a vascular lesion, so the red represents trapped erythrocytes in these abnormal vascular spaces, and visceral lesions look quite similar. They all have a similar histology. The primary cell is endothelial cells, the lining of the blood vessels and the lymphatics. The disease is driven in large part by dysregulated vascular endothelial cell growth factor. There are remarkably altered intracellular junctions such that there is no vascular integrity, so there is quite a bit of tissue edema and extravasation of red blood cells into these abnormal vascular spaces. There's also a very strong inflammatory component, chronic inflammatory component. Treatment is dependent on the rate of progression and the distribution of disease, as well as the underlying immune competence of the individual. There are local therapies for slowly progressive or stable disease. Systemic chemotherapy agents are used for advanced or quickly progressing disease, and then modulation of immune suppression when possible is also a target of therapy. However, this is why I'm interested in this disease. This is some of the very dramatic manifestations of this cancer in Africa, where treatments are simply too expensive. So we're talking about the endemic and AIDS-associated forms yielding an annual case rate of similar to that which we see in developed countries for colon cancer. So this is a significant public health issue in Africa, and is one of the most commonly diagnosed tumors in adults as well as in children, with a 90% mortality rate, again because of lack of access to effective therapies. The causative agent was discovered only relatively recently in 1994, and it is on this graph or dendrogram of some of the known herpes viruses. It plots out in the gamma herpes virus group here, and its closest relative that infects human is Epstein-Barr virus, which we're all familiar with. It's been linked to 3 disorders, 2 cancers, Kaposi Sarcoma and primary effusion lymphoma, as well as the non-malignant disorder Castleman disease. We're going to talk about KS, and this is the in vitro model that I use to evaluate pathogenic mechanisms. In this panel, these are mock-infected endothelial cells, which show a normal morphology of a contiguous monolayer. So the cells grow together, they find their neighbors, and then they stop growing. They behave like normal, healthy cells should. Upon infection with virus, however, there's dramatic morphological changes. So that nice cobblestone appearance becomes long. These are known as spindle cells. And importantly, if these spindle cells are allowed to culture over a long period of time, they start growing on top of each other, which is very abnormal behavior and is the cancer phenotype that we are evaluating in the experiments that I'll share with you. We've used this model in the past to identify different cellular enzyme pathways, signaling pathways that are potentially druggable. And we found some interesting things. c-KIT, receptor tyrosine kinase, that can be blocked with Gleevec. There's been some efficacy shown in small clinical trials. RDC1, or the chemokine receptor CXCR7, no currently available drugs to target this, but has also been shown to be essential for the transformed phenotype of these cells. And hemoxygenase 1 is a stress response enzyme that is potentially druggable with heme analogs, which were in clinical trials, the Stanate trial most recently. Unfortunately, all of these targets have the same problem, is they are novel targets or they involve novel therapeutics, and there's no way this is going to be affordable in the area of the world where the disease burden is the highest. So what do we do about that? Let's look at generic medications. So in residency, I became aware of this lesion. We're all aware of infantile hemangiomas. They are benign vascular lesions that are present at birth, undergo a burst of proliferation in the first couple months of life, and then gradually involute. And it looks very similar in a lot of important ways. So this is a histology of KS in this panel, and this is infantile hemangiomas here. There's different degrees of cellularity, yes, but they're the lesions are full of abnormal vascular spaces, and it's known that infantile hemangiomas are driven by VEGF signaling, just like KS. So, the classic treatment, or historically the first-line treatment for hemangiomas has been prednisone. This young child was on prednisone for 4 weeks, and you can see that there's a tremendous subcutaneous component to this giant hemangioma. and he was in heart failure, high output heart failure, because this lesion was so large. And so propranolol was started to support his cardiac function. And nobody expected this, but this is him a week after propranolol was started. A dramatic difference in the size of the lesion, and then by 9 months, propranolol was discontinued. We're all familiar with this story, and recently we have more formal data to support the use of propranolol. This was published earlier this year by the same researcher who first used propranolol in IH, and they compared 2 doses, 1 or 3 milligrams per kilo per day, either for 3 months or 6 months. And in the initial portion of the trial with 188 participants, 63% of the patients on 3 mg per kg per day for 6 months showed full or near full resolution of the hemangiomas, compared to only 8% of untreated. In the second efficacy portion of the trial, the same dramatic difference compared to placebo was demonstrated. So 3 milligrams per kilogram per day for 6 months seems to be the optimum therapy. And notably, the side effects, hypoglycemia, bronchospasm, low blood pressure, the differences were insignificant between all treatment groups and placebo. So it's also safe. It's also cheap. So this is from the World Health Organization list of essential medications. This is a list of medications that are thought to be, the cost-benefit analysis is such that they should be available in any reasonably stocked clinic in the world. And propranolol is on here for prophylaxis for migraines, but I don't care. It's on there. It is also, it's important to note, it's readily compoundable, it's water-soluble, and stable for a month in solution. So we don't have to refrigerate it. All right, so does it work on KS? Well, hopefully I will convince you yes. I'm going to share with you some of the data from this paper that was recently accepted at Journal of Virology. To begin with, we just did a dose response and counted the number of cells. So in this graph, the solid line are KSHV-infected cells, cells that are transformed and able to grow on top of each other. And the dotted line are uninfected or mock-infected cells, which form a monolayer and stop growing. The readout here is metabolism of a molecule called XTT. So this molecule is put into the culture supernatant. The cells metabolize it into a colored substrate, and that can be read on a plate reader. And so that optical density is normalized to untreated mock-infected cells. So you can see without treatment with propranolol, infected cells grow to at least twice the density of uninfected cells, but that proliferative advantage is lost in a dose-wise fashion, a dose-dependent fashion with treatment with propranolol. And just to verify that mock-infected cells and KSHV-infected cells metabolize XTT to the same rate, we did the same kind of experiment, plating different numbers of cells and measuring XTT metabolism 6 hours after plating, which was not enough time to allow for proliferation. So this truly represents more cells in the infected wells. Now, decreased numbers of cells can either be due to decreased proliferation or increased cell death. So to look at potential for cell death, we measured lactate dehydrogenase. And the black bars are infected cells, the white bars are mock-infected cells, and you can see there's no significant increase in LDH with increasing doses of propranolol, nor is there, that blot is missing everything. So cleaved caspase-3, caspase-3 is the master regulator of apoptotic cell death, and when we look for cleavage of that molecule, it indicates that programmed cell death has been activated. If you will just believe me for a second, the positive control staurosporine is a pan-caspase activator, so that we're very dark bands here and here. Not so much in the KSHV-infected lanes with drug treatment. So very little caspase-3 activation. And the downstream, one of the downstream targets of cleaved caspase-3 is the nuclear protein PARP, and that was also not cleaved in the drug-treated cells. So we infer from this, or from this data, we stated that, or we determined that propranolol decreases the number of KSHV-infected cells by decreasing proliferation rather than increasing cell death. We did some cell cycle analysis to back that up. In untreated cells, this is the cell cycle distribution. So G0, G1, there's 84% of cells. That's the vast majority of them, the white portion of this donut. 7% of cells in S phase, that's the gray portion. And in G2M, 6.4%, compared to an increase in cells in S phase and a decrease in cells in G2M in KSHV infected cells treated with propranolol, supporting the interpretation that proliferation is decreased. Cell cycle is a complex process. So cells have to phosphorylate and activate and inactivate the retinoblastoma protein in order to initiate DNA synthesis. And then other stages of the cell cycle are all mediated by combinations of cyclin-dependent kinases and their binding partners, the cyclins. So we used immunoblotting. Sorry about that. We used immunoblotting to assess the level of these cell cycle regulators. And the first two columns are mock-infected cells, and then KSHV infected cells in the right two columns, and then either treated or untreated with propranolol. And what we found is that in KSHV infected cells treated with propranolol, we're seeing a reduction in CDK4 and CDK6 expression, which is interesting. These two CDKs are predominantly responsible for phosphorylating the retinoblastoma protein, allowing for the S phase to begin and proceed. And we see a similar reduction in the amount of phosphorylated RB. We also saw dramatic upregulation of cyclin A following KSHV infection, and loss of that upregulation when infected cells were treated with propranolol. So to start to tease out which of the CDKs and cyclins were involved, we used various CDK inhibitors. This one is roscovatine, which inhibits CDK1 and 2. And you can see a dose-dependent reduction in the number of infected cells with increasing concentrations of this CDK inhibitor. To confirm that CDK1 or CDK2 was involved, we used siRNA to knock down the expression of the two CDKs and their three known binding partners, cyclins A2, B1, and E2. And using XTT as well, but presenting the data in a different fashion, we looked at the effect of knockdown of these proteins on proliferation. As expected, KSHV infected cells treated with propranolol there was a dramatic decrease in the number of cells compared to knockdown of the CDKs and their cyclin binding partners. We found that knockdown of CDK1 and cyclin A had a very dramatic reduction in the number of cells. There were small but statistically significant differences with some of the others, but we chose to proceed with the two more dramatic phenotypes. And again, we see gross disruption of the cell cycle distribution when we knock down cyclin A and CDK1, confirming that these two proteins are required for KS cell proliferation, which is a novel finding in and of itself, because it was previously thought that the latency genes expressed in KS cells were sufficient to drive proliferation. So this is evidence that those viral genes are important, but don't do the entire job. We also looked at lytic gene expression. So in the majority of cells, with all herpes viruses, the majority of cells are in a latent stage, but they can be reactivated to express lytic genes, which are required to assemble infectious virus particles and propagate the infection. The dotted line in these, this is quantitative PCR. The dotted line is our positive control, PMA, which we use to induce lytic replication for growing viral stocks, compared to propranolol. And you can see that there's a similar induction of all different kinetic classes of lytic genes following treatment. We went back to look at mechanism and noted that we lose CDK6 expression in KSHV infected cells following treatment. And there was one paper in the literature that showed that viral cyclin, one of the latency genes, binds to CDK6 and was required for suppression of lytic reactivation. So we confirmed this by knocking out CDK6 with siRNA and saw induction of all classes of lytic genes, suggesting that the reduction in CDK6 expression explains the phenotype observed. This is unpublished data, but one of the directions we're moving in now, if we can induce lytic replication in these tumor cells and come in with an anti-herpes viral medicine such as ganciclovir, we should, in theory, be able to kill the cells that have been reactivated. And in fact, that's what we see. So in this is XTT again, not normalized. These are just the optical densities. Cells were either treated with, or mock treated, or treated with 25 micromolar propranolol, and either none or a dose response of ganciclovir. So you can see there isn't, as expected, a reduction in the number of cells with propranolol treatment, but that reduction is further reduced with co-treatment with ganciclovir, suggesting that propranolol activation of lytic replication could be used for cytolytic therapy. So in summary, propranolol is a promising therapeutic for KS and primary fusion lymphomas. I showed you the KS data today, but we see similar phenotypes in the lymphoma cell lines. We've shown, which I did not show today, but we found that there is synergy with bleomycin, which is a chemotherapeutic agent available in Africa for treatment of KS with significant dose-limiting toxicities. So this synergy is exciting. And I'm currently working with the AIDS Malignancy Consortium at NCI to develop clinical trials at some African sites. So hopefully next time I give this talk, I will have some clinical data. We are also in the lab looking at mechanism, what's happening upstream of the expression of cyclins and CDKs. We've seen derangements in the vascular endothelial growth factor signaling axis. And we are also following up on the potential synergy with ganciclovir. It seems that across different tumor types induced by KSHV that there is an effect. I'm also establishing a collaboration with a colleague who studies Epstein-Barr virus, which causes Burkitt lymphoma, nasopharyngeal carcinoma. If this is because beta signaling may be a more broad gamma herpes virus mechanism for proliferation and suppression of lytic replication. So, with that, thanks very much to the current members of my lab, to my faculty advisory committee, and of course, all of these sources of funding. Thanks so much. I'll take some questions.
Does the same pathway that you elucidated activate or deactivate in the hemangiomas? Has there been any work actually defining why it works in hemangiomas?
Yeah, so the explanted hemangioma cells that are treated in culture with propranolol actually undergo apoptotic cell death because presumably, one of the proposed mechanisms is loss of STAT3 phosphorylation and subsequent decreased expression of VEGF. Transformed endothelial cells can grow without growth factors, but healthy primary endothelial cells undergo programmed cell death with withdrawal of growth factors. So the mechanism is thought to be shutting down abnormal vascular endothelial growth factor signaling in IH. Well, I think that the VEGF is going to be active here. I think that's one of the reasons we're seeing reduction in cyclins and CDKs, because they're losing that mitogenic signaling. The difference is that KS cells have all of these inappropriate pro-survival mechanisms at work, so they don't die when they have growth factors withdrawn, they just slow down. Yeah.
We used to be interested in this. Years ago, sitting in a tumor conference, Pepper Daner, who Mark probably knows Pepper Daner's name, the pathologist, looked at a kid, slides of a kid we had with a diffuse hemangioma and Kasabach-Merritt syndrome and said, man, if I didn't know what I was looking at, I'd tell you we were looking at Kaposi sarcoma. And in 1987, it seemed like it'd be a really smart idea to run upstairs and give that child some interferon without getting consent or anything. We did. And the hemangioma then quickly resolved, and the kid's DIC resolved, and we felt really proud of ourselves. So this has been an interest here for a long time. The question is related to the doses. You showed a drop-off in the primary impact with the propranolol when you're able to get around 25 to 50 micromolar. And is that a dose?
Which is absolutely not relevant at all physiologically, unfortunately. There is a disconnect between in vitro effective dosing and in vivo effective dosing. So the dose range that I chose for my studies is based on the in vitro work done with hemangioma cells. So no, those levels are not achievable, but it's also a single dose given a 48-hour period as opposed to in a patient getting twice daily dosing for 6 months. But there's the pharmacokinetics for propranolol at 2 mg per kilo per day. The maximum concentration achievable in infants is less than 1 micromolar. So it's a very big disconnect, but we know that despite that disconnect, it works for propranolol, or it works for hemangiomas. We just have to try it in KS to see if it works. And there's one paper that showed topical timolol worked for treatment of a case of classic KS. So there's evidence that it may work. We just have to try it.
Other questions or comments? It's hard not to think of EBV-associated lymphoproliferative syndromes in solid organ transplant patients. That's one disease we see here. And it seems like with rapid extraction of information from large data sets now, one could quickly gauge whether or not the use of beta blockers in solid organ transplant patients stands out as some kind of a marker in a multivariate analysis for EBV-associated lymphoproliferative syndrome. I don't know if you ever thought about something like that.
Definitely interested in looking at the behavior of EBV-infected cells treated with propranolol. I don't know the answer to your question, but I can say there is a lot of work. There's a lot of interest in using beta blockers as adjunctive therapy for solid tumor chemotherapy. All solid tumors need blood vessels to grow into them in order to survive, and propranolol can help shut down that tumor angiogenesis.
Might be an interesting side project for some of our oncology colleagues in the audience. Well, so that concludes our presentation today. I'd like to thank both scholars for outstanding summary of their work, and thank you all for your attendance.